Good morning. You're all very welcome to this morning's meeting, which is hosted by UCD EVIBEC team. We're really delighted to invite you to a practice exchange of innovations in EBP education, and we're also really pleased to have had the chance to be sponsored by the National Forum for this event, so we'd like to thank and acknowledge that. I thought I'd start by just highlighting one or two housekeeping comments. We thought we would push things to the limit by making this a hybrid event in such times, just when we've all got used to technology online. We're pushing ourselves and trying to get used to in-person online. So we'd like to welcome all of you that are joining us online, and we hope to include you as much as possible. We'll be asking you to take part in polls. We'll be asking you to share your screen if you feel that's appropriate and ask questions to our audience here. What I would note is that this session is being recorded, and we'll be asking people for their agreement to have this recording shared afterwards, because that's the recommendation by the National Forum. If that is the case, we'll need to get your signed consent. If you don't want to participate in that way, we ask you to switch off your camera and remain mute, and you can put questions in the chat, which is going to be fielded. We think we've tried out the sound here with our centre. We've got great IT help from our UCD Student Centre, but if anyone experiences any difficulties hearing what's going on, please type that in the chat, and we're fielding people on the chat to make sure that we can deal with the problem. So we hope you enjoy this. We're hoping it's going to be an informal event, because we really want to bring everyone together and thrive on the diversity of healthcare professionals that we have here, and really that's what EVIBEC is about, building on that. I want to just tell you a little bit about the programme we have ahead of us now, because I think this is really exciting. Our keynote address is by Dr. Eve O'Toole, Chair of EBP Ireland. She's going to be talking about the importance of EBP to healthcare programmes. Then Dr. Lehane will present about UCC-led project looking at EBP teaching in Ireland. We'll have a short comfort break then, and then we'll introduce the UCD EVIBEC team and our new interactive curricular framework. And a series of people will present about work that they've been doing and what's on our interactive framework. We'll show you around the interactive framework, and then finally we want to open the floor, virtual floor and real floor, for an open debate, and we hope that you'll stay to join in with that process. So we think this is an exciting program ahead of us, and hope that this will give people time to think, stop and think how we can work together, because the purpose of this is really sharing resources, sharing expertise, and bringing together the expertise across the country and beyond. So it's my great pleasure to introduce to you Dr. Eve O'Toole next. Eve is co-founder of Evidence-Based Practice Ireland, and this is focusing on building capacity for evidence-based practice in Ireland. Eve has an MSc in evidence-based healthcare from the University of Oxford, and also a PhD in biochemistry from UCD. She's a strong advocate of evidence-based practice and has been teaching in this profession over 15 years. She's head of Evidence and Quality Hub at the National Cancer Control Programme and leads development of clinical guidelines. Her expertise ranges from development, use and teaching of evidence synthesis methodologies, and also she is a member of the National Clinical Effectiveness Committee subgroup for education. So it's my great pleasure to introduce Eve to you now. We'll just switch over to her slides so that you can see those.
So good morning, everybody. Firstly, I'd just like to thank you for the opportunity to be here today. And it's particularly nice to be back in UCD, where I studied many moons ago and did my PhD in biochemistry. And it's particularly exciting to be live for the first time in a long time, but to have an opportunity to talk about one of the things that I'm most passionate about in life, which is evidence-based practice. I think we would all agree that lots of time passes in our lives with very little significance. And I'm not just talking about days or weeks, but whole years can merge into just mixed memories. But then there are those days where our lives change utterly, in an instant and forever. These days not only change the circumstances of my life, but they change me to the core. How I think, what I believe, how I behave, and who I am. And in October 2005, the first day of my master's in evidence-based healthcare in Oxford, I had no idea that that would be such a day. But from that very first day, and I have to admit, it was the PICO framework that grabbed me and changed who I am forever. It changed how I have worked all day, every day since that first moment. I think it's the PICO because a frame to ask questions just appealed to everything about me as a scientist. It brings me back to second year in my undergraduate studies, when there was a big plaque on the wall in one of the biochemistry labs: science is not about learning the answers, but asking the questions. And here was somebody giving me permission to ask many, many questions and a framework to do so. But when I reflect back now and think, what was it about that week? And I went to do a short course in EBP and then signed up for the master's by the end of that week. What was it? So of course it was the content. Evidence-based practice is very gripping because it gives you tools from the very outset that change how you practice every day. But it wasn't just that, it was how it was taught. It is an adult education paradigm which was so different to what I had experienced before. This built on your own existing knowledge. It built on the knowledge of the other people in the room. It challenged us to think and change our behavior, not just learn knowledge. And really, it was the peer-to-peer learning in a multidisciplinary environment where we all came with different experiences, different knowledge, and could learn from each other. This was not about your core subject knowledge. This was about how we do things. And I think that's ultimately what appealed to me so much. So why do we need evidence-based medicine? And I'm going back to one of the founders, Sackett. And in 1995, he wrote this seminal paper discussing evidence-based practice and the need for it. And he said, as physicians, whether serving individual patients or populations, we always have sought to base our decisions and actions on the best possible evidence. The ability to track down, critically appraise for its validity and usefulness, and incorporate the rapidly growing body of evidence into one's clinical practice has been named evidence-based medicine. And this was truly groundbreaking, because this was really the advent of the importance of the randomized controlled trial. But of course, we all know now that the best evidence to answer a question totally depends on that question. It's not all about the trials. But what was really important in that paper also is he talked about this concept of moving from mechanistic reasoning, which had been so prevalent in healthcare, to focusing on patient outcomes. And I think really that is at the core of what we talk about now as evidence-based practice. Which brings me to a diagram you'll probably see many times today, and probably much more beautifully drawn. I've had a sneak peek of somebody's. But really, I prefer this, and this is what I base everything on. It's the integration of the best research evidence with clinical expertise and patient values. And I love the fact that we have practice in the middle. And there has been a big move, and the Sicily statement in 2005 really addressed this. This isn't about medicine, this is about evidence-based practice. Now, I like the word practice because it challenges to change behavior, but practice incorporates the wide range of healthcare professionals. And they identified in Sicily in 2005 that we often have more in common with our peers who practice EVP than we do even with people in our own profession. So this is really important. The language we use here is so important. But what I love about this is it puts the patient at the center. So of course, this is so explicit in individual patient contact scenarios when a clinician is treating an individual patient. It is about them taking the best evidence that they have found, using their clinical expertise, and looking at what that patient values, what outcomes are important to them in making joint healthcare decisions. And we often refer to that as shared decision-making. But it is more than that. I love this diagram because I don't work on an individual basis with patients. I work developing guidelines for the most part, or evidence-based policy or clinical recommendations. And this diagram very neatly reminds me about who I should always have included in the room. I need to have people who can generate that research evidence, who can critique it and can do that with expertise. I need to have representation from all relevant stakeholders, clinical stakeholders, all of them in the room. And this also involves not just the obvious, the doctors, the nurses, the allied health, physios, OTs, whomever is relevant. But we've discovered recently, it's also the people who administrate. How are we going to implement? And we'll talk about implementation later. And if I don't understand the process in a clinic, I won't get an implementation plan in place. And most importantly, it gives us a mandate to bring the patient into the room. And this is something that has really changed and developed in Ireland in the last few years. But really, we need to explore their values, think of their agency, what matters to them as an individual, what matters to them as a population of patients. And I think that is something that hopefully at least all of us here agree. Sorry, it's not. So again, this is probably something really familiar to everybody here. The 5 steps of EB, and that's EBM, because that's how it was first introduced, and that should have been changed to EBP. So it was to identify a knowledge gap. So this is all about deciding, where do we need to change? What's our gap in our knowledge? Because there are thousands upon thousands upon thousands of questions we could ask every day. So it's been very clear, what do I need to know now? And framing that answerable question, we search for and locate the best evidence to answer that question. And I've already said that this isn't always about going to your randomized control trial. It's the evidence to answer the question you have. That can be qualitative. It can be for prognostic information. I do a lot of work with diagnostic people. We're looking for really good cohort studies. It depends on your question. Then it's critiquing that evidence, looking for really, when we say validity, how biased is this? If I apply this to my population, will I expect to get the same result? Everything is biased. There's flaws in every study, but we want to know how biased and which is the best evidence, which is the least biases in it. And if they're there, what direction do they go in? But we also want to think about the usefulness. And people talk about statistics a lot, but I always think about, what's the clinical significance? Is this going to change anything for my patient? Is this going to be useful? And you have to think about the applicability to our Irish healthcare system. Then we come to the really nub of this, and we gloss over this a lot when we teach EBP. Then we integrate the best evidence with clinical expertise, patient values, a little bit of magic, and we apply it in practice. And that encompasses so much of the challenge. How do I integrate that evidence with the clinical expertise? How do we engage the patient without them losing even more agency? How do I really listen and engage them? How do I apply it in practice? How do I implement it? What are the barriers? What are the facilitators? How are we going to do this? And then, so important that we stop at the end and go, how did I do? And it's not just auditing outcomes, though that is really important. We need to also audit process to see how we implemented with fidelity or successfully, but also what can I do better? And I do that with my own team regularly. We sit down and we look at all the frameworks we use and go, okay, how can we adjust these? What do we need to change? I've borrowed this from the Centre of Evidence-Based Medicine in Oxford, and I really like this diagram for the 5 A's, and it's a really lovely sum up. Ask the question, acquire the evidence, appraise the evidence, apply the evidence in practice, and then assess your performance. But what I like about this is that it sort of switches the whole paradigm on its head. It starts with the asking and growing as you go along, because the most important piece is actually applying the evidence. And underpinning it all is this quality improvement cycle that we always reflect, audit, and see how we can improve things. So that's why I've put this here, because it gives us pause for thought. Why don't we concentrate more on the apply? So David Sackett also said, the issue is no longer how little of medical practice has a firm basis in such evidence. And we all only need to go to PubMed today to see the explosion of trials and systematic reviews and all of these things. The evidence does exist for a lot of our questions. But the issue is how much of what is firmly based is actually applied in the front lines of patient care. So I'm going to bring you to one of the classic examples that you've probably all seen, but just in case you haven't. But I really like this one because it's impactful. And what I like about it, it addresses Sackett's original point about mechanistic reasoning, as well as the delay between research and getting evidence into practice. So Benjamin Spock was a really famous writer for childcare. There was over 1 million copies of this, 19 million copies of this sold, 50 million copies. They say it was only outmatched by sales of the Bible. And if you look at the picture here, what we see is a really bouncy baby lying on his tummy. And I've used this in classrooms and get people to describe what they see. And it's amazing. Some people always do pick up that the baby is on its tummy. So he said in this book that the disadvantages to a baby sleeping on his back, if he vomits, he's more likely to choke on the vomitus. So this is mechanistic reasoning. He thought, baby on the back, if he gets sick, he's going to choke. So it's preferable to accustom a baby to sleeping on his stomach from the start. But then we have our trials looking at this. And you can see that there's an over 4 in our lovely forest plot. And if we had all the time in the world, I could talk about those for a long time. Over a 4-fold increased risk of sudden infant death syndrome, if you look at that triangle at the very bottom. But actually, if you add each trial's results to each other, as you see on the right-hand side, by 1970, it was known that there was a statistically significant increase in the risk of SIDS for front sleeping compared with sleeping on the child's back. So it was obvious from 1970 that there was an issue with putting a baby on its back. And if you talk to people who were born in the 70s and asked them to go home and ask their mothers, a lot of them were still put to sleep on their tummy. And in fact, it goes way beyond that. So this book with that lovely pic was issued in the 50s. The first study to suggest harm was in the 60s. Second study was in the early 70s. And at that stage, it really was statistically significant. Further studies appeared in the 80s, but it was the 90s before the Back to Sleep campaign started in the UK and the US. And the systematic review we looked at was published in, I think, 2004. So it shows this huge delay from getting the evidence that did exist into practice. And if we think about outcomes, death is such a definitive outcome, such a traumatic outcome. Well, book still exists, but a very different picture. So we talk about evidence-based practice and we talk about applying it to individual patients, but of course, we all work in a healthcare system and we have to think of value within that system. So I don't talk about value as just money or cost effectiveness, but those things do come into healthcare decisions and they do come into recommendations. But value-based healthcare is the equitable, sustainable, and transparent use of the available resources to achieve better outcomes and experiences for every person. So if we think about that, it makes us think about value in a very different way. And this comes from the Centre for Evidence-Based Medicine in Oxford as well. And if you ever have the opportunity to listen to Sir Muir Gray, he talks a lot about this. But we need to talk about equity. We need to talk about sustainability. And we're not going to keep getting more. We hear the debate, the politics, all of this about we need more resources, we need more resources. There isn't an infinite amount of resources. So we have to think how we use those resources better to achieve better outcomes for everybody and equally distribute it across society. So when we think about evidence-based practice integrating and meeting value-based healthcare, there are major international problems. They're not just Irish in healthcare. One of them is unwarranted variation in practice. So this is in both access to healthcare, the quality of the healthcare you receive, the costs of that healthcare, and outcomes for patients. There is overuse in our system. We do things every day in our healthcare which are just leading to waste and indeed sometimes patient harm. It's not just that we're doing them good, we're actually doing harm. And underuse, we're not getting those new technologies, those new interventions in quickly enough, those that do improve outcomes and are often cost effective. And that also leads to inequality and failure to prevent disease. And I think the whole idea of population health and prevention has become huge awareness in the last 2 years with COVID. But evidence-based practice gives us an opportunity to address all of these things and focus on the main drivers. So we can reduce variation in practice, and we can do this through policy, through guidelines, through protocols. It allows for optimum allocation of resources, and it allows us to quickly adopt high-value interventions and technologies. So one way we can reduce variation in practice is the production of national clinical guidelines. And I'm putting this in here because that's another passion area for myself, and it is my day job. I am the head of the Evidence and Quality Hub in the National Cancer Control Programme, and we've developed a suite of 8 national clinical guidelines for cancer, the first that we've had. So that's a really exciting development, and it addresses that concept of variation. This gives recommendations for the delivery of cancer care, diagnosis, staging, and treatment for all patients in Ireland, no matter who you are, no matter where you are. We also spread this not just from those areas, but we go right through to primary care, and we're starting to do follow-up protocols as well. So I just want to give you some little examples from those areas. So fast-track adoption of high-value interventions and technologies. So a really nice example recently is we had a clinical question in one of our guidelines for men with prostate cancer referred by a urologist: is MRI recommended pre-biopsy? So we discussed the quality of evidence, benefit and harm, patient preferences and values, resources, capacity, and other considerations. And our final recommendation was that in men with suspected prostate cancer referred from a urologist, a multiparametric MRI is recommended pre-biopsy. This has the potential to save somewhere between 25 and 30% of men having a prostate biopsy when they've suspected prostate cancer. And that's huge from a patient perspective, because it's a very invasive procedure with a risk of sepsis, but it's also huge from a healthcare delivery perspective. And most of these men get an MRI at some point in the trajectory, so it's really moving it earlier into the patient pathway. Optimum allocation of resources. So, sorry. I just want to come to this one first. This is a really good example as well. I know you can't see anything, and I don't need you to see anything here, but I just want you to show this is the MRI question. We have updated our approach to developing guidelines. So before it was more an evidence review. So we would summarize the evidence and make a recommendation, but now we're really explicit. And again, it's going back to the concept of the research evidence, the clinical expertise and patient values. So we actually print out a short piece on what the evidence is, the benefit and harm to patients, so it's really transparent, the preferences and values and what underpins those and drives those. And in this case, dignity was a huge driver for the patient. And we explore those with an ethicist in the room. And then we look at the resources, and we take all 4 components when we make a clinical recommendation. Optimum allocation of resources. So I'm going to a really old example, and there's a reason I'm doing this. So this was back in 2015. And this was one of the first examples where in the room, we had our clinicians, we were asking a question is what groups of patients with breast cancer should have staging investigations to detect metastases? And the conversation at the very beginning was, well, we can't stop this. We couldn't possibly tell our colleagues they can't have staging investigations. And then we said, yeah. And then we went into our process, and we start with always what is the evidence? And then we go into all those other domains. And it became very clear that there was really no evidence to support staging patients with early stage breast cancer. So again, we would save a lot of resources, but also there's huge anxiety for a patient going through these staging investigations. So it also was of huge benefit to the patient. So that was really quite a game changer in terms of getting clinician engagement, that they realized their recommendation was very different to what they expected it to be going into the room. And that's the beauty of taking an evidence-based approach. One of the other great things about this, and the reason I chose this example, was the project manager on the breast cancer guideline was Dr. Niamh O'Rourke, who's based in HIQA as head of standards. And that was very serendipitous for me, because Niamh had a huge interest also in evidence-based practice, and we bonded over that. And really that is what's led to the establishment of Evidence-Based Practice Ireland. We were both lucky enough to be attending Evidence Live in Oxford, doing a workshop on generating guideline recommendations. And we met with representatives from the Nagy Foundation, which are a philanthropic group whose raison d'etre is to promote the use of evidence. And we had a conversation around establishing Evidence-Based Practice Ireland, with really the main goal being to create capacity for evidence in Ireland. We wanted to create a culture where evidence-based practice is how we deliver health and social care services. And today is the first day that I'm using the logo because we've only just signed that off, and Elaine is in the room. She's one of our committee members. And one of our committee members who stepped down recently, Dr. Dunico Grody, he suggested the salmon of knowledge as our symbol to give it an Irish heritage, which was very appealing to all of us, and the whole concept of the salmon of knowledge. But also we thought from an international perspective, what will be appealing about this is the concept, if you give somebody a fish, you fed them for a day, but if you teach them how to fish, you've fed them for life. So there was a dual aspect to our logo. So as I say, we really wanted to promote the use of evidence-based practice in health and social care with the ultimate goal, of course, of improving patient outcomes. So we said, what are the barriers? Because if you think about this, this is really embedded in so many other countries. And why were we lagging behind? And we always feel this when we go to international conferences. And we really looked at that and broke it down. And we said, there's a couple of key things we need to address. So if we want people to be evidence-based practitioners, we have to teach them evidence-based practice. And really this needs to start in their healthcare professional training at undergraduate level. So we wanted to see, well, what's happening at undergraduate and postgraduate level? And Dr. Lehane will be talking about that afterwards. We then thought, well, we need to say, what should we be teaching them? And again, that's addressed in the Sicily statement in 2005. What should we teach? And again, Dr. Lehane is going to talk about that. But then we said, well, there's actually existing healthcare staff that have had no exposure to EBP. So we need to provide training for them. And if we're going to do all this training, we need EBP educators. So we're going to have to give people training on how to teach. And really, this can feel like a very lonely journey. And I found the people around the country over the last, heading for 20 years who are interested in this. But how do we find each other easily? And we decided we need to create a network and seed people with this passion throughout the country, because that's how we're going to create change. So as I say, the baseline research was carried out, and you're going to hear all about that. And a competency framework was developed. And I really want to acknowledge both Dr. Lehane, but also Dr. Neva O'Rourke for really driving this part of our program. She was based at the time in the Department of Health and secured funding from them to deliver this piece of the work. So I would also like to acknowledge the Patient Safety Office and the National Clinical Effectiveness Committee. Both Neve and I, and again, the serendipity of it, were members of the educational subgroup for the NCEC, and that allowed us really drive that piece of work. And again, acknowledge Professor Dermot Malone, who was leading that subgroup and who also has an absolute passion for EBP and has been teaching it for well over 20 years. So for the training for healthcare staff, we set up a collaboration with the Centre for Evidence-Based Medicine in Oxford, and we wanted to work with them because we really wanted people to feel that they were getting value coming to a course. We wanted to learn from their expertise and their expertise in teaching. And we've slowly been phasing out their involvement in these courses. And we provide a 3-day workshop for 50 healthcare professionals. We carried it out in November 2017 and also March 2019. Unfortunately, the latest course was cancelled, but we're hoping to do that soon, and we will include you all in our advertisement. Some of the feedback from our 2017 course was that people had enhanced skills in developing questions, searching for evidence, and critiquing the evidence. And this is quite common following courses in EBP. They knew about that they needed to look for evidence to support interventions, but they did report back a lack of ability to implement or change practice. We got our feedback both on the day and then through reflection essays from the participants. So when we redesigned the course for 2019, we decided to develop a teaching model on evidence into practice because we wanted to empower healthcare professionals to become evidence-based practitioners. So this is our whole 3-day workshop itinerary, but I just want to focus on the last day, the last session, which was the evidence into practice. So we talked about developing clinical practice recommendations. So that was, how do I integrate the evidence with clinical expertise, with patient values, and apply. We had a really wonderful session on evidence into practice, shared decision making. This is a huge challenge for people as practitioners when they sit down. How do I communicate that evidence to a patient? How do I ensure that they have understood what I'm saying? And there were some brilliant examples there. And then really, it's no use if we don't have an implementation plan. How do we do that? What frameworks can we use? We need to start with the end in mind from the very beginning, all of these key pieces. And then in the afternoon, each of the small groups, which were multidisciplinary, had to present from the first day a question they agreed as a group, the evidence they found, what their recommendation would be, and their implementation plan. And that was really successful. So we really changed the course. A common element of the evidence into practice, we gave them frameworks. We used real world examples from our areas of expertise. And again, working with a multidisciplinary group can really work well because you learn the principles often more with examples that you're not familiar with, because it really can connect and resonate. And we gave everybody a hands-on opportunity to try out the new information. They were all practical sessions. Our feedback changed after that course. They were using evidence to challenge current practice for service redevelopment, and the reflection essays were about 3 months later. They were developing recommendations, they were implementing change, identifying barriers, developing workshops, and using evidence when communicating with patients. So the feedback we got was very different having introduced that session. And here's just a pic of the group in Dublin Castle. So for training of educators, again, we've used Oxford as our link. And so far we've trained 13 EBP practitioners in their teaching course in the last number of years. And what we have done to build the capacity and for people to use their new skills is that when they come back from Oxford, part of the contract of getting the scholarship from us is to do so many hours of teaching with us. So they've all become facilitators on our course. And just a little quote, excellent workshop, would recommend it to everyone, thanks to the wonderful facilitators. So it gave people the confidence to teach, to have some formal training. And then we come on to the establishment of the network. So the EBP network was launched in 2019. And really this was to increase the capacity and use of evidence-based practice in Ireland and to foster that culture in health and social care, for evidence is how we do things. So again, we used the 2019 workshop to create this network. We used interactive sessions and we had a psychologist on our group, Mary Morrissey. She used icebreakers, creative thinking with facilitators, interactive networking sessions. Everybody was asked at the beginning what they were bringing in terms of experience, what they were hoping to get. We had a social event. They were asked what would they do as part of the network, what do they want in the future involved in EBP Ireland, and we collated it all. So that gave us a really good idea of what the gaps were and what people wanted. From this and from both the workshops, from the first workshop, we got a lot of our volunteers who went to do the training course, and we now have an EBPI steering committee with wide representation and again, a very multidisciplinary group. So our next steps as EBPI, are building our EBPI platform, and at the beginning it'll be an IT solution, and you can see we've just launched our logo. And we want to really gather and collate tools for evidence-based practice for both practice and for teaching. For us, it's all about sharing and collaboration, and that's why it's wonderful to be here today. We shouldn't all be independently creating all these resources, we should be sharing them. And that was one of the biggest messages I ever got from Oxford. They're so generous with all their information, with their slides, with their teaching resources. This is about a global movement. This is about healthcare for everybody, and we really should be sharing. And we really are moving to the phase of embedding our EBP network. So some of the challenges. Evidence-based practice is essential to the delivery of clinically effective care with improved patient outcomes. But if we're to do this, and we're all to do this, then we need to have it as a core component of healthcare professional training. This has to be how we work. If we're to do that training, we also need to consider how we put evidence into practice. So we have to start teaching and tackling the applied domain. And we need to create a cultural change, because again, we often connect more with our colleagues who think around EBP rather than we do with people from our own profession. And this is all really hard. This all goes back to what was said in 2005. So this isn't new, but this is the future. I just wanted to mention COVID-19 because I don't think we can talk, and this is my first live talk since COVID-19. But what's our learning? What can we take from that as a community? Well, one of the things I learned was around quick and efficient production and publication of new evidence synthesis. We were turning guidelines out. Within the first 2 to 3 months, we did 24 guidelines, and some of those were changing every week. That was facilitated by wonderful clinical engagement because they had a need. So they suddenly understood the need for this, and we're really happy to work with us. And we've had wonderful clinical engagement since also. So I think we need to be more agile in our evidence synthesis methodologies, and we have to sometimes stop letting the great get in the way of the good. To quote Mary Morrissey, you know, a done one is a good one sometimes. And I'm not saying we need to throw out our rigor, but we need to be more agile. I think there's an increased awareness out there in the population on the importance of evidence. Patients are going to start asking these questions because there's been such debate in the media around evidence. There's a broader understanding of some of the concepts. Now, they were touched upon, like diagnostic tests. My sister was asking me about antigen tests, and I said, well, if you have a positive test, it rules in the disease, but negative doesn't rule it out. She's like, I get that. You know, these concepts are now coming out there into the public, and we need to keep driving that. I'd love to have been able to explain the impact of prevalence on the antigen testing and why the recommendations changed. But, you know, and I think we need to start having those debates. Seamless working across healthcare programs. COVID opened doors that weren't open before, and we need to keep them open, working with your colleagues, and your colleagues aren't just your own profession. Clinical engagement, the EBP community, we're meeting a clinical need. The HEI library just blossomed because people knew evidence synthesis was needed. Time to publication changed utterly, which is just fabulous in terms of getting evidence into practice. The HEI evidence service, synthesis services, and the repository now for guidelines and PPPGs established. We got evidence into practice because they needed evidence to address new infection prevention control, the impacts on capacity, potential harm of contracting COVID-19, etc. Evidence got into practice in real time. We reduced the variation in practice very quickly in COVID. We created living guidelines that were changed as needed. There was the agility, but it raises issues for me around ethics in healthcare decisions. We didn't have much ethical debate. And I think it would be good to have more open discussion. There is the evidence, but how do we go from evidence to recommendation? We all are advocates for patient values, and societal debate and population debate around where our values lie, how we balance benefit and harm is very important in those debates, and I think should have had a bigger voice. Generating clinical practice recommendations, and it's the same point, it's more than just research evidence, it is all of those other things. And we see that there has been great harm as well as good done with some of the restrictions for children, etc. So we need to always think about and maintain the balance. Priority setting nationally and internationally, there was pooling of resources, not just in Ireland, but internationally around evidence during this time. And we need more of that because we shouldn't all be repeating the same work. And that requires collaboration, both national and international, because there aren't endless resources again, and we all should be working together and prioritizing what needs to be done. And really the bottom line, it just shows that EBP is an essential skill for all healthcare practitioners. I'm wrapping up and I know I'm a few minutes over. I just want to acknowledge Dr. Niamh O'Rourke, co-founder of EBPI, and all the members of the steering committee, and you're about to hear from Dr. Lehane, Professor Dermot Malone, who was the chair of the educational subgroup in the NCEC, and also a mentor around the area of EBP, the Centre for Evidence-Based Medicine in Oxford, because I can't say how generous they are with their time, their tools and everything. I want to acknowledge Naji for awarding us the grant to allow us get this all up and running. There's the contact information for people who want it, and they can get it through Emma afterwards. And just there, the logos of some of the people we've worked with. And there's great groups in Ireland like Evidence Synthesis Ireland, the Library Services, Cochrane comes in under Evidence Synthesis Ireland, etc. So these are all places to go for further information. Thank you.
I want to thank Dr. Eva Toole so much for a fantastic, thought-provoking speech. That was such a fantastic keynote to start this session off. I've got a page covered in buzzwords and questions and comments, and I've just realized that she put her finger exactly on why I love evidence-based practice. It's that it legitimizes my but why approach to life. So I'm going to now be really bold, having said that we've but why, and ask you to hold questions at this point. I'm sure there are loads of questions out there. I've got pages of questions, but what we want to do is move through our speakers at the beginning so that we can really have an active debate later. And this is what we really want this session to do, is bring together both audiences with trepidation, I have to say, with some of you online and the face-to-face. It's all very new for us all, going back to face-to-face and trying to combine that. But I know we're going to have loads of questions. So now it's my great pleasure to introduce Dr. Lehane, who's Associate Professor at the School of Nursing and Midwifery at University College Cork. She's a registered general nurse and has practiced in the area of neuromedicine and renal care. Her key clinical interests are in chronic illness management, specifically supportive care strategies and professional workforce development and evaluation. Her principal teaching scholarship interests include teaching of evidence-based practice and interprofessional teaching and learning dynamics. Dr. Lehane has led or actively contributed to a number of national and international projects, including Magnet for Europe, the National Irish Hospice Foundation guidance document on medication management for people with dementia, Nursing and Midwifery National Turnover Study, the National Cancer Survivorship Needs Assessment, and also in teaching of evidence-based practice across the healthcare professions. So I'm really delighted to welcome Elaine to the stage now.
Thanks very much for the invite, and it's great to be here, and it's great to see these initiatives taking place and specifically focusing on evidence-based practice. So while I'm here presenting, it's on behalf of an interprofessional team, and you'll see that they are they're predominantly from the College of Medicine and Health in UCC, but we also work with colleagues in the RCSI and the School of Public Health here in UCD. And it's also really important to acknowledge the support that we've received really since 2017 in relation to the work that we've done. And as Eve has mentioned, from the NCEC and Dr. Neil O'Rourke and Professor Dermot Malone, also the NAGI Foundation, EBP Practice Ireland, and I didn't have the logo, Eve, since it was just launched. And again, the expertise and the advice and the sharing of resources really from CEBM in Oxford, and also from the Institute of Evidence-Based Healthcare in Bond University in Queensland in Australia, in particular from Dr. Leo Albuquerque in Bond University. So I'm grateful for their support, and I'm presenting on behalf of our team. So I was asked we're going to get into probably the research that has served as the basis for the work that we have done to date. And it started off in 2017. And I'm going to spend probably most of my time looking at the 2017 research findings, and then run through the competency framework, and also look at the two most recent projects that we're working on, and that's the development of toolkit resources for educators of evidence-based practice. So educators both in academic settings, but also in clinical settings as well. So they're toolkit resources under development, may I add, so it'll be snapshots of them. So the first project back in 2017 looked to determining the current provision, practice and variation of EBP education in Ireland. And basically what we were looking to make were key recommendations to educators, clinical and academic, and policymakers in relation to best practice for EBP education. So I'm going to focus mainly on the findings, but I'll bring you through our methods. So it was 3-phase multi-method approach. The first one would have been the structured rapid review. And I emphasize rapid because this project was for a duration of 9 months, and it included a national survey, and it also included interviews, so plus ethics. So for those of you in the room familiar with that, it was tight. So for the rapid review, we were looking at 3 key questions: current practice here in Ireland, most effective components of EBP education, and also the effective components of the EBP curriculum structure and considerations that are put into that. So we had 83 papers from the database searching, and we also looked at grey literature. The phase 2, and this was the most enjoyable from my perspective, was the international expert interviews, and we wanted to get some more nuanced information about those who were considered expert in their field, about what they thought the future of EBP education was. So this was before the advent really of Zoom and MS Teams. So we went to Skype, and when Skype invariably failed, we went to Telecon. So all experts waived their right to anonymity, and I'll go through that slide later. And then the final one was the National EBP Teaching Survey. And we sent out invites to 81 deans or their equivalent in terms of the HEIs and the clinical education settings, etc. We got about a 68% response rate, 54 that were representative of the courses, whether they be undergraduate, postgraduate, CPD. So getting on to the findings. So the rapid review, to be honest, for those of you who are well versed in this, nothing that you wouldn't have expected didn't come up. So participation in any EBP education is good. Most curricula align to the 5 steps in the EBP or in the Sicily statement, but with an overemphasis on 1 to 3 in academic settings, to be fair. Most apparent trend in positive changes was seen from, again, not surprising, multimodal EBP teaching interventions, so not just your didactic lectures, but there is no unequivocal evidence to suggest which components are more effective than others. The SRs just don't show it at the moment. And few studies were conducted a follow-up assessment past the 6-month period. So they focused on knowledge and skills, but not necessarily the behaviours thereof. And that goes across, I think, health and social care profession education. And the grey literature, open door, open grey, etc. But really, we're looking at the policy documents and the regulator and professional accrediting body documents in relation to their emphasis on EBP as a competency, and more implicitly than explicitly, EBP was mentioned as that competency. Did I click on? Sorry. Okay, phase 2, the international experts. So you can see them there. Professor Lehane from Australia, Gordon Guyatt, Rod Jackson, Bruce Arrell, and Professor Carl Hennigan. If I was to critically appraise this, which I always do, the 4 out of the 5 experts were based in medicine. Yes, some were men. And the only person outside of that was Professor Lehane from Australia, and she would have been coming from the speech and language therapy perspective. But I suppose we were looking for those who, had a lot of experience in this area. So maybe another one is due in terms of looking to more international experts. So those interviews are very enlightening and put some context into the literature and to the rapid review findings. And essentially what they were saying was the overall arching theme was improving healthcare through enhanced teaching and learning associated with teaching healthcare learners about EBP. And when I say healthcare learners, I just don't mean your undergrad students. I'm talking about all healthcare learners. So how do we do this? Well, we need to look at curriculum considerations, how we teach EBP, and stakeholder engagement. And the curriculum considerations look to where we focus on our competencies, how we integrate it into the curricula, our teaching strategies and approaches, an emphasis on who's teaching EBP and how confident or comfortable are they in all the elements of it. And then looking at stakeholder engagement, looking at the input of national policymakers, whether it's on their agenda, patient enablement, shared decision-making being really important. And again, looking at healthcare professional engagement. So those healthcare professionals who are out there with a number of years and what do they bring? So just, and I can't see the screen, so I'm hoping you can see that one. We're going to concentrate on maybe just a few elements of the subcategories that came through. Again, for those of you who are well versed in this, unsurprising, the ideal is an integrated academic and clinical curriculum. It's a very complex ecosystem. There's a lot of negotiation around that. So that's the ideal. And learning levels. So I mentioned that, you know, you're looking at your curricula in terms of, are you teaching undergrads, postgrads? Is it a CPD course? Are you looking at very kind of, I suppose, experienced practitioners and clinicians, and what are their viewpoints? So it goes back to the basics of assessing them when they come in, who is sitting in front of you, and then kind of going from there. EBP competencies, the literature would say it. Eve has mentioned it. We focus on 1 to 3, steps 1 to 3, particularly at undergrad level, but that apply step is very tricky. And how do we integrate it, particularly introducing it at an undergraduate level, and what resources do we need? Teaching strategies, relevant. So particularly at an undergrad level, I suppose I'm just speaking from my own experience. I have 250 nursing students in front of me at undergrad. They would much prefer to be in the clinical skills lab and the simulation suite. And we have a standalone separate modules that go from first to fourth year and continue on post-grad. But I can see it in their faces. But when you start looking at talking about relevance, and when you spend that time just teasing that out, I've seen light bulbs go off much quicker when you change that focus. The examination of skills, perhaps not content, how do you integrate that skills teaching? So they're in the lab looking at blood pressure, but it's not just that skill they're looking at. How are you integrating the evidence into that? So how are you getting that in different ways? Looking at EBP educators, very strong emphasis on the training of educators who are delivering EBP as opposed to delivering research methods. And I see all the nodding faces, heads here, and that's a key element of it. It's very different. And yes, the evidence and the research is part of it, but it's a triad, and you put up your slide about the triad and saying it's only one part of it. And clinicians with the X factor. This came from Rod Jackson, and he was speaking of those people with the X factor. I'm presuming Australian X factor was on at the time, but he was saying you have your clinician, and they listen to the patient, they ask the relevant questions, they can get and appraise the evidence, and they can communicate that, and then they start all that back over again, depending on where that conversation takes them. And not only can they do that, but they can actually teach how they do that. So that's the clinician with the X factor. And we're hoping that they be more common in future. National policymakers, in terms of that kind of coordinated national approach to how we teach and how we deliver EBP. Coordination is the key word there. Patient enablement, shared decision-making is coming into the lexicon, not in a kind of a tokenistic manner, but in a meaningful way. And how do we engage in that? And then healthcare professional engagement in terms of changing that professional culture, and COVID has really expedited that process. So that was the run through of the expert interviews. And then, so Carl Hennigan ably sums it up there in terms of the main point of healthcare education and how we teach it. Okay. onto the national survey. Looking at that, I'm just picking out key elements, I suppose, related to the teaching of EBP. And if anybody wants to read the 122-page document, they can do so, but I'm just picking out those key elements. So in terms of the percentage of time allocated to each method, now remembering this was conducted back in 2017, so it's a few years ago now, so maybe things have changed, but standalone EBP modules, didactic teaching essentially. It's a way of delivering, with the least amount being it integrated into a clinical setting. So that goes across undergrad, postgrad, CPD. Okay. Then in terms of EBP learning activities, number one, searching and retrieving the evidence, and we have our set courses, and that was the highest mean score in what it is that we teach, followed by accessing electronic resources for finding appropriate evidence, and then the critical appraisal, and a big emphasis on that as well. Lowest mean score about students participate in evaluating the effectiveness. Again, more complex to try and integrate. Assessment of learning, well, thankfully, most people agreed that they did assess the learning, and I'll move forward to how we did that. Again, unsurprising for those who are the representatives, I suppose, of answering this, a very positive attitude towards EBP, that it's an essential part of healthcare and social care professional practice, that it helps clinicians and it improves quality of patient care. Methods used to assess learner knowledge and skills. Unsurprising again, I think, written exams, followed by CATs, but less so in terms of the application of CATs in a clinical setting. So we can see the trend, and I'm sure you're all aware of it, in terms of trying to get that integration of the curriculum between the kind of the academic site and the clinical integration of it. So this was a really poorly, I think, phrased question, helpfulness of strategies to help EBP. I could have come up with a better way of doing that, but probably one of the more interesting slides. So evidence of improved, so what is most helpful? So staff access to courses to enhance their knowledge of EBP, which was interesting. So access to courses to enhance their knowledge of EBP, and then after that, access to courses to enhance their knowledge of how to teach EBP. So there is a piece there, I think, in terms of educators, whether they're within the academic setting or in the clinical setting, and their own confidence in their knowledge of EBP, again, as opposed to research. So that was interesting. And then after that was the enhanced knowledge to teaching it. A national agreement on EBP competencies, clear and closer working relationships with librarians, and I really could speak about that all day, and the politics involved there, and revision of curricula to include enhanced time on EBP. But really, from my perspective, again, in an ideal world, that EBP, you learn the principles and you're standalone, but it should be woven and integrated across all of what it is that we teach. So go back to the blood pressure, simulation, skills labs, etc. So there was an open-ended question about general comments in relation to EBP teaching. So that seamless integration was a suggestion in terms of all aspects of a professional curriculum. The use of technology and virtual learning, and I suppose that is we're more au fait with that now, and hopefully that will help us. Educators who can walk the walk, in imparting practical evidence-based clinical knowledge. So walk the walk in terms of how we research our own teaching about how we teach evidence-based practice, and how we show our students and the healthcare learners that we're actually doing it, we're applying it to education, which is really important. And then providing students with opportunities to experience the value of EBP. So you talk about values in terms of healthcare user, service user outcomes, but actually the students want to see the value of that experience of EBP in the real world settings. And that comes back a lot of the time in the real world. So ivory towers, real world, etc. Bringing it all together in terms of those 3 phases. So national agreement on the minimum standard educational requirements, core EBP learning objectives, clinically integrative, interactive, multimodal, easier said than done, increased discourse between academic and clinical educators, and I probably should have put in there, increased meaningful discourse, as opposed, you know, in terms of, okay, the curriculum might already be developed, but can we go back and reevaluate, and what does that look like for us? And some professions have more experience in doing that than others, I would suggest. Further emphasis on skills relating, and this was an important one that I think came out of the interviews in particular, about how we teach the communication, not just general communication skills, but the communication of evidence within the context of shared decision making. So that apply element, how equipped are we in teaching that? So that was an interesting one. The other one that both Professor Hennigan and Professor Guide were they highlighted a lot, was about the searching principles, and how clinicians are not going to be going on to CINAHL or PubMed and Medline and doing your extensive search. How are we integrating the likes of UpToDate and clinical summaries, etc., and how are we teaching that, and are they aware of that? And, you know, so that was something else, the pre-appraised evidence. So if, as I said, if you want to read the 122-page document, it's on the NCEC website. There is a summary document, but it's still quite long. And then there's an open access publication on that expert review or expert interviews on BMJ EBM paper. So that was I suppose the run through of the first piece of work back in 2017. And then the second project built on that in relation to the standardized or looking to a potential standardized framework in relation to the competencies. So it was expanded to clinical effectiveness, which, as you know, is the EBP is a core component of it, but you can't have EBP sitting on its own. It's an incorporation of your QI process, your quality improvement processes, your implementation science initiatives and strategies. And the piece, I suppose, that we introduced as well was the collaborative practice, because EBP is within, you're hoping that it's done so within an interprofessional nature. So we were tasked, the team again, or I suppose we're tasked with developing this competency framework for clinical effectiveness education across health and social care professions. A very brief run through, because I'm looking at my clock, about, again, this multi-phase, multi-method approach. And we had this consolidation report, which we wanted to look again at these core competencies, not just within EBP, but also across QI, IS. We didn't find the collaborative practice piece until after the consolidation report. And we looked at relevant international education competency frameworks that were in existence, because we're not really fans of reinventing the wheel. So we were hopeful that there was something already out there. There wasn't. We collated information from the NCEC forum proceedings. We built on the National EBP Teaching and Learning Project. The scoping review that Leah Albuquerque had completed, that was just kind of hot off the presses. And we also looked at, across the health and social care professions, their professional regulation requirements and standards. So we also engaged stakeholders in a consultation process, so 13 stakeholder groups hosted in Cork and Dublin, and there were, I think, about approximately 50 participants across those 13. So they were in the afternoon, and there was a lot of teasing out of the proposed competency framework, and then there was a sign-off of the final framework after that. So that was the competency framework. Not sure if you can see that. So it looks at the 3 core elements. It gives the definition of clinical effectiveness. It incorporates your EBP, your QI processes, your implementation of clinical effectiveness into practice, and then the all-encompassing piece that affects each of those elements would have been your collaborative practice. So to look through each of the domains, I suppose, we adopted with permission from Lehane, his work, his consensus statement on EBP. And the indicators really were to understand the fundamental or core concepts associated with EBP, to structure clinical questions, to identify and recognize relevant sources of research information, to critically evaluate, to engage with evidence in a daily practice. I think that we had a lot of talk about, is it engage, is it apply, is it, there was a lot of talk around there, but very importantly to reflect upon that kind of knowledge translation piece. The quality improvement processes, the indicators there would be to, or I suppose the rationale for us would be to, that the QI processes really need to be part of the efforts of learners to make changes that are clinically effective. And in doing so, I suppose the competencies associated with that or the indicators would look at the fundamental or core concepts associated with QI, identify areas for quality improvement by doing your kind of gap analysis almost, to apply quality improvement processes into practice and to reflect on that. We took the same approach in terms of IS. So this is trying to incorporate them all together and looking at, again, understanding the fundamental and core concepts associated with IS, identifying the challenges and enablers, and applying the apply and effect in terms of how successful or not they were. And the collaborative practice piece was cross-cutting and a significant influencer on the EBP, QI and IS strategies. And we're looking to things like supporting interprofessional collaboration and the knowledge and skills associated with that, how to communicate appropriately, and to determine best leadership approaches. So some principles underpinning the framework there is that it was designed with a view to apply to all health and social care professionals with the competency domains, generic and universal, that it assumes evidence-based practice is an interprofessional collaborative effort, and it places the service user at the center of professional learning. And with this document, there are curriculum consideration, teaching and learning strategies, and assessment methods associated with that. Again, that document can be found up on the NCEC website. Its strengths and limitations are that, the development process was rigorous, that the competencies were reviewed and refined in an iterative manner, so there was consensus building there. However, I suppose the most disappointing part for me was that despite several invitations to service users and patients, that their input wasn't present in it. So if you're talking about a competency framework who has the service user at its core, yet they haven't inputted into it, then that's obviously a limitation of it. So the validation of the framework is still required in relation to that, and work hopefully will get underway in that after COVID, if there is such. So the building capacity competency framework publication, again, is open access in BMJ EBM journal, and there's a summary document which is mainly full of graphics and presentation slides, which is easily usable on the NEC website. Okay. So coming towards the last two projects, and because these are under development, there's a lot less to be said to them about them. But again, this builds on the 2017 work that we did, and looking at that piece, okay, there are quite a number of courses out there, particularly from Oxford, McMaster, that give you resources about forest plots and what's the triad, etc. But there's less so in terms of teaching the teachers, training the trainers as such, and looking at their confidence and how comfortable they are in teaching. So we were tasked to develop toolkit resources for educators to promote and harmonize the teaching of competencies related to evidence evidence-based practice across academic and clinical healthcare settings. So this has resulted in EBP Toolkit for Teachers. We're still deciding on the name. The second one, which has just gone to the learning technologist at the moment, is the interconnecting evidence-based practice and shared decision-making. So the first toolkit is kind of an overarching, goes through the 5 steps and has resources according to that for each of the steps in terms of how you might teach or resources that you might use. And then the interconnecting EBP with the shared decision-making, that one just focuses on the apply step specifically and how we might look to integrating that. Methods, again, we're excellent at scoping reviews and reviews in general at the moment. We've done so many of them in this area. Consultation with a national group at this stage who have been teaching in this area some 5 years, more 15 to 20 years, and explore the experiences of teaching EBP in Ireland at national, organisational and professional fora. So this is specific to Ireland. There's content development in terms of the scoping review results, in terms of the consultation piece, and it is an iterative process again. So when it's released, it will be evaluated, slightly amended and put out there again. So I just wanted to maybe show you some, and we're coming towards the end there, some screenshots essentially of the resource. It's currently hosted on Canvas, on UCC Canvas, and it will be released public as a public resource, obviously, but its intention and our hope is that it will be hosted on the EBPI platform so that we can have all of those resources in one central repository as such. So we have the introduction and we have 3 units associated with that. And there's reflective pieces for educators. There's not too much interaction because obviously we're very familiar with developing resources and if there's an interactive piece, and probably the team wouldn't be on 24/7 in relation to answering queries, but there are interactive, reflective, think and pause points, etc. It's a toolkit, so you can go in and out of it. So you can follow the unit 1, 2, and 3, or you might say, look, I'm fine with asking questions, I'm fine with searching the evidence, but I might need a few more resources or ideas about how to appraise something. And there are already completed appraisal papers that have been appraised. And there are, say, papers on how to teach uncertainty. Because uncertainty is something certainly that the undergrads and some of the newly qualified grads, well, you know, everything is black and white. Absolutely not. I can't give you that answer. So you're going to have to consider your triad, but be okay with the uncertainty, but you just have to navigate that uncertainty. So those kind of papers in terms of how we approach it. So you can follow it, or it's kind of like an a la carte menu. You can just pick and choose what resources that you need. So again, these are just screenshots in terms of reflective pieces for the educator, for the person who's looking at it, where they can go for help. And then there's the more focused zones in terms of, well, we're looking at the apply domain now here, what's out there in terms of tips for teachers, tips for learners, etc. Yeah, that's it. It's 31 minutes, so that's not bad. Okay, thanks very much.
So once again, we're absolutely spoilt with our speakers this morning, and I hope that everyone here and on Zoom is enjoying the session as much as we are. We've got a pause now. We're going to take a pause for the next 15 minutes. I think if somebody from the audience could remind me the time we come back in. I've left my sheet behind. Catherine. 12:05, we're going to reconvene again. So we give you a chance to grab a coffee, everyone, to write out your questions. So what we're going to rejoin to discuss is the EVIBEC project at UCD, and then really open the floor for discussion at home and, well, online or here. So we'll reconvene at 12:05. So welcome back, everyone. I hope you're feeling refreshed and ready to go, because we've got a lot planned now for the second half of the session. So what our plan is, first of all, to introduce the EVIBEC project and have a little discussion about what that meant, but then show you some practical examples, sort of from the coalface, as it were. And we hope this will spark off a bit of discussion between all the groups. So we're very excited about this session. So the EVIBEC project was born several years back at this stage. Catherine Redden, myself and Robin Farrell were chatting in a teaching and learning meeting one time and decided we were all reinventing the wheel in our own little education silos. And we thought it would be great to bring together a team of like-minded individuals and see should we work together rather than always trying to reinvent the wheel. So I'm going to pass over to Catherine to introduce a little bit more about the project, and then you'll meet several of our team members as we go on through the next session.
Thank you very much, Emma. As you can see, we are an interdisciplinary group from all different healthcare professionals in UCD. So we have a representation from the School of Nursing, from Agriculture and Food Science, from Public Health, Physiotherapy, Sports Science, from Veterinary Medicine and Veterinary Nursing, from the School of Medicine, and from the Health Sciences Library. And as Emma just mentioned, we came together as a small group first, and we were discussing evidence-based practice the way it was currently taught in our disciplines. And all of us were having similar problems with students finding it very difficult to have to be introduced to evidence-based practice in an end of program, usually in stage 4 of the programs. And it was a capstone module that delivered the evidence-based practice. And across most of the disciplines, this was the way it was at that time. This is how we taught evidence-based practice. And listening to the students at that time, they were finding this extremely difficult. And we wondered, was there another way to do it? Could we embed it into our programs? So as we started to meet over the course of time, the group grew and grew with everyone with similar interests. And we eventually came up with the EVIBEC project. So with our project, we wanted to have meaningful collaboration among ourselves, among the different disciplines that we're teaching evidence-based practice, and with key stakeholders. And we included here students, our academic and clinical colleagues, to design a framework with a clear view to implement evidence-based practice within our health professional curricula, be it undergraduate or postgraduate curricula. While we were embedding the evidence-based approaches, we wished to develop student higher order skills and graduate attributes across our curricula. We wanted our framework to be interactive and dynamic, and also open to be shared, so that we would grow a community of practice of health professional educators and other educators that were interested in evidence-based practice. So again, this is Sackett's definition of evidence-based practice. And we all were working from this basis that we would agree the best scientific evidence, integrated with patient values and clinical experience were the definition that we accepted of evidence-based practice. We have common core elements to all our evidence-based practice. So we were looking at all healthcare professionals must be able to gain, to assess, to apply and integrate new knowledge into practice, and that we would use the 5-step model of evidence-based practice for our framework. And that's the 5-step model. And again, you looked at that this morning. So we did want students to be able to ask an answerable question at the end, to be able to appraise the evidence, to acquire the evidence, then appraise the evidence, to apply the evidence to a clinical situation or another relevant context, and to be able to evaluate their performance at the end of the step, the 5 steps. So we used this 5-step model, and then we also looked at the literature that was out there. So a lot of that literature, as you can see, you were discussed this morning, and it was great to get the actual authors of the literature here. And it's opened up a lot of ideas for us. So we looked at the published evidence-based competencies that came from the National Clinical Effectiveness Committee, and we wondered then how to set out learning outcomes for each of those competencies. So in total, there are 68 competencies for evidence-based practice. And we started to look at using Bloom's taxonomy, so looking at the different levels of cognitive levels, and tried to map the learning outcomes to each of the 5 A's. So I'll give you an idea of what our first framework looked like. It was very primary, the very first one, and then we started developing it over the last year. So it is a vertical framework. This is what was advocated in all the literature that came out, that the core competencies should be linked to the learning outcomes, that there should be an interprofessional focus to teaching and delivery. So that's why we have an interprofessional group, that there should be sequencing of the competency indicators. And again, with a vertical integrated framework, this allowed us to sequence all the learning outcomes. And then the last recommendation from the National Clinical Effectiveness Committee was use of clinically contextualized, interactive and multimodal teaching and learning strategies. So as we were doing our framework, we were also listening to the students to find out what learning outcomes that they might think would be helpful for them to attain these competencies. So this was one of our first efforts at doing a framework. We put the 5 A's along the top. Then we looked at Bloom's levels of cognition along the left side, and started to work out the learning outcomes for each of those A's. But as we were doing this, we found that maybe to be able to ask an answerable question, there could be 10 learning outcomes under the level of knowledge and another 10 under comprehension. So very quickly, we realized we had to have a more dynamic platform to host this. So we used Padlet. So our interdisciplinary group was busy trying to get some idea over the vision that we had for our framework. And we knew we had to meet with the students to get their ideas as well. So we set up a series of 4 co-design workshops. The first 3 were with students, and the last one was with practitioners and educators. For the co-design workshops, we used Zoom because this occurred during COVID. And we also used the collaborative platform of Mural. And this worked out really well. It really helped us to get good collaboration from the students and to be able to listen clearly and verify each other's work. So I'll just give you a very small idea of what went on in each workshop, and then they'll be gone into in a little bit more detail. So in the first workshop, we asked the students, we had 33 students that agreed to participate in this project. And these students came from all the different disciplines, and they came from either the last year of an undergraduate program or a postgraduate program. For the first workshop, they stayed in their discipline, but the other workshops, we mixed the different disciplines together. And there was a different facilitator in each of the breakout rooms to help with the workshop. So the first job that the students were given was to think for themselves of what were the characteristics of this evidence-based practitioner. So what was spoken of earlier as the X factor. So they described the skills and behaviors of people that they would put up there as being an evidence-based practitioner. And then they thought as a team of what currently promotes them to acquire these attributes. So they started to think of different learning activities and skills that they were acquiring in practice and in academia that was going to make them become an evidence-based practitioner. The second workshop, we asked the students to focus on the key components of the 5 A's. And this was a very powerful workshop, mostly because of the structure of our mural for this workshop. And again, that will be presented to you shortly. The students were able to look at the work of the group ahead of them and were able to verify and add to each group. In workshop 3, we had the students identifying key learning activities for evidence-based practice. And these were ones that they would really like. They may have met these activities in evidence-based practice or in other parts of their programme. And because these students were coming from both undergraduate and postgraduate programmes and had coming from different professions, there was a wide variety of learning activities that they proposed here. And these were really good ideas. There are many international students, and they were talking about things that they would have done in different modules, not just evidence-based practice. So we got the students at this workshop to pick 10 favourite learning activities that they saw and to make a sales pitch to the group as a whole on these learning activities. They mapped these activities to each of the 5 A's as best as they could. And they also mapped them to programme stages when they would like them early in the programme, the middle of a programme, or the end of a programme. So it didn't matter how long that programme was, they were able to map these activities to the different stages of the programme. And the 4th workshop, we were very lucky to be able to hold it at the INHEAD conference, which is the Irish Network of Health Educators. And that was online as well. And here, anyone that came to our workshop give permission to have their data used for this project. And they were asked to brainstorm how to implement and disseminate the framework. So they were looking at from clinical practice to throughout programs and from local to national and maybe international. And we got some really good ideas from the participants here. But we also got a lot of information on the enablers and barriers to implementation, especially into practice, because we had, as I said, practitioners at this workshop. And I'll hand over to Emma to continue with this. Thank you.
Thanks very much, Catherine. So what I thought I'd do is just really give you a taste of some of the workshops. I don't intend to go into them in very much detail, but I thought that we could share some of our thoughts on them, what we did. And I think it then gives you an idea of where some of the information that Charlene will present has come from. So Catherine mentioned our first workshop was really having our student group consider the characteristics of an evidence-based practitioner. Now, while this doesn't directly inform our approach per se, I think it was important in establishing the dialogue with our student stakeholders, because we really wanted to get them in the zone, as it were, of thinking, what is it we're trying to achieve? What's evidence-based practice in the programme all about? Where do you want to be going forwards? And really get them thinking about that and get them comfortable with discussing. So that first workshop, I think, was very important in that regard. And I think it was a really key thing that we had 33 students from across lots of different disciplines and undergrad and postgrad students all in together, because they all brought such different experiences to the table. So what you can see on the screen now is a copy of the mural that students were able to work on. I don't know whether you're used to using mural or not, but this is effectively a structured dynamic whiteboard, for want of a better description. You can see the little post-it notes in the middle. Students or anyone working online with this can zoom in and then start sharing post-it notes and reading. And really, it's a very, very good collaborative platform. So we were able to gather up their thoughts and collate their thoughts on what it meant to be an evidence-based practitioner from this, whilst setting the scene of what they would want out of a programme if they were really trying to imagine things again. So the sort of things that we had out of feedback from this is that that they felt that they needed to be doing practical things. They wanted to be doing facilitated and working within groups and with their peers, and that they felt that trying to work through skills and integrating ways of really putting things into practice was important. They wanted to have smaller chunks of knowledge assessed rather than big pieces, and really what came out of it was that that's actually what I should reverse and say is one of the first things that came out of it was they did view it as very important. So that was obviously fantastic to know at the outset. But what they really did feel was they wanted to generate the skills and learn the skills, and they recognized that they really did need a variety of skills in order to be effective. So the next workshop, I think, was my personal favourite, but I think was a favourite for everyone, because it really was I can't read it off the top of the screen, a cafe, World Cafe style. I can never remember the name of it. But what we effectively did was had this one giant work screen for everyone to work to that they could zoom in. So we set a group working on their particular ask, and they'd start at the outside of the circle and consider what their understanding of their particular A that they were on, what it meant, and what sort of key components there were to achieving that A. And then once they discussed with their group, they got to move around to the next A, see what the previous group had thought, add to that, validate that, and contribute, keeping their own little post-it notes for their group's colour, and then move in through the circle, then considering how they might start learning those skills, and then starting to think about the sort of activities they might be doing in order to gain that as they moved into the third section of the wheel. So they got to look at several of the A's, look at several different other groups' work, and move on through. So this was really then setting the scene for our final workshop, which is what we wanted to collate the most information from, which was considering the types of learning activities that they thought might facilitate them in learning the skill base they needed. I should say as well, the one thing that I also think was very helpful for our perspective was also seeing if there are any areas that the students found confusing or didn't understand about the A's, and that came out of the dialogue as well, which I also think is very useful information that will feed back out of this process in the end. So this gives you an idea of this final third workshop with the students. What they were doing was thinking of ideas, and then they had to do a sales pitch on what they liked and decide what they thought were the main sort of activities that they might like. And they're very inventive. I think sometimes we're guilty of not asking the students what appeals to us, and there's no point us thinking what we would have liked 20 years ago when the people that are much more relevant are right in front of us. And we're lucky enough to have one of our student participants who is a postgraduate as part of this to present in a few minutes' time. So what did the students say? Well, they found the workshops were very useful. They found that the dialogue was beneficial. They actually really enjoyed the process, which was interesting because you think, well, we thought they were doing us a tremendous favor, which they were, but they actually really seemed to enjoy the process and found it a good learning experience themselves. But they did appreciate being given the voice. And I think that's something that's really important for us to remember as educators. They also really flagged the interdisciplinary approach and felt that that was beneficial. It got them out of their bubble and made them really start thinking in alternative ways. And I think that if I had to flag one thing that I've learned the most from this whole program of us collaborating as part of the EVIBEC team is interdisciplinary, interprofessional education is the way forwards. We really can bring strength through our diversity. And I think that's something that I would really like to be the biggest take home of this whole thing. So I'm now going to take a leap of faith and hope Charlene's about to pick up the in the background there. Can you hear me, Charlene?
I can, yeah. Thanks, Emma.
Perfect.
Hopefully people can hear me.
Relief to hear your voice. So I'm going to hand over to Charlene now.
Great stuff. You're going to have to move the slides though, Emma.
Oh yes, I best not walk off. That's a good idea.
Sorry. So in terms of the key things that students actually brought to the table, and you can see these are just a selection of some of the main suggestions that students had for the ask, so the first A. So the first one that we had were from the early stage. So it was things like educators going in with a general topic. For example, here they suggested something like diabetes. And then the students were being asked to decide what question they would actually like to ask and bringing that to the class and then presenting that back. So actually composing the question that they wanted to ask in the clinical topic. Similarly, the second one there is asking the students why things are the way that they are. So actually getting them to question the clinical topic. So getting that question formation happening early on in that early stage. And one of the things that I thought was quite inventive was that the sort of that game that you play as a child, the what am I one, which was about how to ask a question so that one partner has the answer in terms of what the clinical question was, and then the other partner has to ask questions to find out what the original question was. So one that covered the other side onto the other side of the slide is one suggestion that could cover off all stages. And things that the students suggested were games on how to practice identifying, say, a study design by reading just the methods section, or perhaps having fabricated descriptions of different study designs. And another suggestion that they had was similarly another type of game, which was Pico this paper, which we thought was quite creative. So perhaps if we could go on to the next slide, Emma. So for Acquire, they had quite a variety of suggestions of things that could go across early, all stages and late stages. And the ones that we kind of thought were in sort of a similar vein in the early stage were things like interactive tutorials. And they want these things early rather than typically we had found that the students were saying that they were kept till later on in the program, but they wanted them earlier in the program. So how-to sessions, you know, things like how to navigate journals, using Boolean operators, etc., how to download and as well as use citation manager tools. Things like being a detective in essence. So going in, looking at a set topic and asking the students to go and find what are the top 5 most cited papers in a topic. So that they can do kind of trial and error assignments. Games like Who's Who, so what source are you? So that was the name that they suggested. So like a database quiz that they've got to go in and find the source of something through going through a database and finding the source for a paper. And similarly down the bottom, there was asking questions to bring a piece of evidence, so a paper or whatever piece of evidence they need to bring to their practical classes, so that that might support the treatment or the assessment technique that's being covered in that class that day. For all stages, the things that they suggested were things like examining and finding things like practice guidelines, consensus statements, and gold standards, so that they actually know how to find them, A, and then B, what they actually look like. Other suggestions were things like guideline-based quizzes, so that students get good at finding evidence and searching the literature with somebody like a near peer, so that they can do it in a way that's approachable to them and troubleshoots things in a way that's approachable to the student. And then for the late stages, they had quite an inventive one, which was around guidelines through the ages, so that they can actually think about how treatment options have evolved and that new evidence has fed into it. So I really liked the Eve's one about, say, for example, you know, how SIDS has evolved and the treatment option in terms of suggesting that babies are on front versus back facing was one example there of, you know, guideline evolution. So if we could go on to the next slide. So when we move on to appraise, you can see that, you know, the more commonly used ones for early stage would be things like tutorials, absolutely, and you can see that they go across into all stages. But things like bringing checklists into the early stage was something that they were quite strong on. And they had quite a creative one, and I know we mentioned the X factor earlier on in one of the talks, but they had a different take on it, which was something like, this topic's got evidence. And so it was splitting students into groups and judging an evidence whether it was good or bad. So basically it's kind of like pushing the buzzer on whether or not a paper was good quality evidence or poor quality evidence. We thought that would be a good early kind of game to play with students. For things that were for all stages, they thought that providing exemplars of what was critical appraisals of well conducted and poorly conducted studies, things like picking a topic or a question and looking at different studies to see which different types of methods might be better to address different questions in terms of the understanding which one was going to work better than another. And then also spending time in class with breaking down papers so that they can understand the elements and how they help them to address those components in the class time, so they can see the value of breaking down a paper's elements in that appraisal technique. So seeing it live in action is something that they felt was needed to be done all the way through a program, rather than just, you know, when they had to do it by themselves on their own. And in that late stage, they felt things like group projects where they're critically evaluating and presenting a paper. So being able to defend why research was actually poor quality or good quality was more important in that later stage. So next slide, please. So for apply, as per what we've seen in the earlier presentations, they found this one much more tricky. They were a little bit more sparse on the ground for apply. So for the early stage, they felt things like real examples that people living with conditions worked through, as in consultation with the students was the suggestion that they had for a more early stage. They could see the application. And then in terms of the late stage, they thought about things like providing tricky clinical dilemmas, what was the evidence that was used to guide the practice, case journeying as a practical, so getting a practitioner to come in and to talk through a case, honestly, and to identify where were the decision points that were made in the treatment and how the evidence was used. And things like students being asked to clinically reason the treatment and to how they made the assessment techniques while on clinical placements, sort of as a presentation or something like that, more so as a late stage piece. So just the last slide. So for assess, they had for early stage, that evaluation piece, writing a popular science piece using a primary source where they've evaluated the evidence and tried to make sense of it. They felt that was something that you could potentially do as an early stage. For all stages, a patient care report of cases seen on placement. So looking at the research to see if the care that was given was backed by the evidence and what could have been done differently. And then more so for the later stage, a case write-up that asks for alternative treatment options to the current plan, things like practicing mock audits with other colleagues, and things like reflection on the week and what was learned in placement. So those are just a smattering of the kind of suggestions that the students came forth with across mainly that workshop 3. Thanks, Emma.
Thanks very much, Charlene. What you can't see, I don't think, because of the technology's not managed to capture everything, is there's lots of nodding going on in here. So I hope there's lots of nodding going on in Zoom, but I can't see everyone. You have to kind of get used to taking the leap of faith this way, because we have to feel each other's presence rather than see it. So are you touching on this one, or am I, Charlene, just to show how seamless our transition is? I think I'm touching on this one. So our fourth workshop really was looking at, we were lucky to get a slot in the INHEAD Health Educators Conference. And really we presented what we'd done so far and had another workshop to really start trying to see what other health educators, and quite a lot of those were clinicians teaching evidence-based practice, which was great from our perspective as well, was we wanted to draw information from them on what they felt might help at modular level, stage level, but really trying to bring through thoughts on how we might bring everything together. Because I think the message I'm getting as we're listening to people presenting from all the different perspectives in here is it's about integration and a cohesive voice. And that's really what we were wanting to get ideas for, to try and gather that information. Now, we're not in a position to present as much of that data at the moment, but that will be something that we'll have to come out of it. It certainly gave us ideas about things we need to think about as we're trying to present some of this. And also the other thing that I thought was very interesting that came out of that was interprofessional education is a huge area now, and quite rightly so, because the only way you're really going to speak with a clear voice about anything, as we're seeing with COVID, and I thought Eve's comments about COVID and what we've learned was really important, is that actually if we all understand each other's language and start using the same language. It's great that now the public are wanting that. I mean, my own kids are not that old, but they're already asking me about sensitivity and specificity of diagnostic tests, which is something that I used to get blank faces from students years ago. So I think that's only to the good. And I think what we want to do is start thinking about ways of getting the story to weave it through the interprofessional education. And their discussions are around what's a good conduit to promote interprofessional education. And my voice, loud and clear, is evidence-based practice, because it's a great platform to do that. And I think something I'd love to see us doing going from here is actually really shouting with a loud voice, you guys that are interested in interprofessional education, we've got a great conduit for you, let's join forces, because I think that that could be really powerful. But I'll not go off on one of my little digressions. So what I want to do just briefly now is show you, we've been talking about our interactive framework, and I know as a vet, I didn't introduce myself, but I'm a veterinary clinician. They say don't appear with animals or children. Well, I'd add technology to that. So I'm going to take the leap of faith and hope that this link actually works in a second. This is a simplified version of our framework, just so that people can get their head around how it works. In that what we did was we started looking at the learning outcomes that would build towards students developing all their competencies, and we mapped them to using Bloom's taxonomy, so that it became very clear what aspects need to be dealt with at different stages in order to build the skill base to progress. And what we hope is that it makes it more tangible for bringing this through a curriculum. So we've used language of the doing language, for want of a better description, so that it makes it easier for educators to think, how are we going to achieve that? And we think it will make it easier to map through and give that unified voice from early education through onto the clinic floor. So that's what we're hoping to achieve with this. So I'll go into the framework now. You've oriented that it's color-coded according to Bloom's taxonomy, and it just take a second to load. So this is our landing page. We'll share the link with you. Just, it tells a little bit about our project and our aims, and also about who we all are, so that you can learn. We'd love you to add to this so that we keep this story growing. And I'd hope this is something we can have a discussion about, because I see all of the groups that have come here are passionate about spreading the word and growing the story. Let's work together. I think all of us about collaboration. Can we meld all of our approaches together? I'll go into our curricular framework now, and I would be quick to say this is work in progress. But what we've done is we've got a little overview of how to navigate this. That will load in a second. I don't know why those load more slowly, but we've got our 5 A's across the top, and then below, and we've got all of the learning outcomes using Bloom's active language and coded according to Bloom taxonomy levels. Now, it's obviously a lot to see at once, all on one page, but what you can do is go into a particular A. And again, I have to be patient, which isn't always one of my virtues. And then that loads up individually. So it's difficult to show on this laptop because it doesn't show all of it, but you can see all of those different A's. And then what we've then is started building, that there are resources relating to those as well. So once that loads, the resources we've got here are our student-led resources. So we've got feedback what we gained from the students, all collated as Charlene's presented. This is just in a little bit more detail. And then links, but what this is just really to show work in progress. So if I go back there, I can use another one, maybe a praise, and we can go down and have a look. I should actually, do you know what? I'll go in the other route because it's quicker, so we can go straight to that A. And then we've got the A out there, but then we can go into our resources, and it just shows you the platform lends itself very well to sharing, because when this loads up, oops, which it didn't, did I press the wrong thing? It's got video links. Yeah, there we go. I thought I'd done something wrong. So we've got shareable video links, we've got links to consort, we've got learning resources, and this is what the next few presenters are going to do, is show some of the resources, because everything's easy to arm wave and say, you teach it like this, but actually people want to see tangible ways of doing things, and we're about sharing, and that's what really brought us to the table. It was one of the key things that brought us to the table in the first place. So what we'd love to see out of this is educators sharing resources, because then we're not all reinventing the wheel, and we've all got different strengths that we bring to the table. And another thing that I think that Joseph's going to touch on is that actually this doesn't need to be discipline specific, and often it's better if it isn't. So we hope will convince you that this is the way forwards. I just need to work out how to get back to my slides. There we go. And so just some other outputs from our project briefly. We developed a little graphic to talk through this.
Is central to all healthcare professions. It is.
So I won't go through that now. People can have a look at that afterwards. It just tells the story of this little project. This practice exchange is really, we wanted to just start the conversation again, see can we really spark everybody sharing resources and working together. And we think it's really exciting that everybody's nodding and is sharing a lot of similar viewpoints. So let's move this forwards. And I'd now like to invite Katrina up.
So good morning, everyone. And yes, we have been behind the camera all morning, nodding and sharing ideas. And this is just an opportunity. My name is Katrina Cunningham from the physiotherapy program here at UCD. And I just wanted to give one example of a learning activity that we use for driving evidence-based practice learning. This is a stage 3 module that I coordinate in clinical exercise on the physiotherapy program. These students have been out in clinical practice education. They have started that journey in clinical education. So we simply give the task of your physiotherapy manager has asked you to develop a manual for physiotherapists to support the rollout of a new evidence-based exercise program for adults aged 60 plus in a primary care area to promote bone health. And so this is the challenge that students are given. We use, and again, I apologize that the Zoom is covering the top of this slide. We use a workshop format, and this assignment runs over the course of the module over about a 7-week period of the module. And embedded within the learning around exercise, there are learning activities related to some of the A's of evidence-based practice. And the first one would simply be in the ask domain. If we look at it, and I visited our framework to see was it functioning for this process, and it does function nicely. If you go to the Bloom's level, it's the learning outcome would be to construct a well-structured question using PICO. And so this is a learning activity that I engage with the students in class, where they construct a PICO in relation to delivery of exercise, defining the population that they're going to address. And this causes a lot of angst with the students. Is it all people? What age group? The intervention exercise, no intervention being the comparison group. And really, I think one of the areas that emerges strongly from the students is they're not really clear on that idea of primary and secondary outcomes. And that challenge as well of if you're working in primary care, can you just take a primary outcome, or do you need to serve across the different domains of outcomes? And that's a real challenge for the students, and one that we try and hone in on, what is your primary outcome here for this cohort? As I say, this is the ask domain and the learning outcomes. And in that case there, we were going to the structured question. But just to say that you can use that framework to inform the design of learning activities that you might embed into a larger scale assignment that the students are doing. Again, if I went for a learning activity in the acquire zone, well, again, to the apply level in Bloom's, the learning outcome might be to devise an appropriate search strategy using PICO to address a clinical question. And again, the students do this for this assignment. They go and they try and acquire the evidence. So the manual assignment of creating this manual for physiotherapists, so an audience that have evidence base and understand evidence base, they're creating this manual, but within this module long assignment that we scaffold learning activities, they can work towards these learning activities in relation to specific A's. And I suppose just to say, these are the outputs that the students produce. They do produce this booklet that is to drive the delivery of an evidence-based exercise program in practice. Now, obviously, the students sometimes go very rapidly to the doing phase because they've been in clinical education, but the rubrics demand, and the assignments and activities that we embed demand that they focus on that, asking the right question, acquiring, appraising the evidence, and then synthesizing the evidence. And they're learning to convey that evidence as well to a physiotherapy audience for translation into clinical practice. And I think that's interesting, that the whole area of are we applying or giving opportunities to apply? One of the challenges we have is that our students don't get that experience of delivering exercise programs to the level we'd like in clinical education. And that's because there's still a very acute care focus in our clinical education and the clinical education structure, unfortunately. So to that end, we did set up a clinical education placement here in the Sports Centre in UCD, and myself and colleagues have our students going on placement to a physio hub here in the gym in UCD, where the focus is on translating exercise evidence into practice with cohorts from the community. So lots more we could say, but that's my few nuggets from physiotherapy. Thank you.
Hi there. So I'm Deirdre O'Donnell. I'm coming from the School of Nursing, Midwifery and Health Systems today, and I'm following Katrina in just demonstrating one of the learning activities that is now embedded in the Padlet as well and shared through the Padlet, and one that I use at different levels of teaching. So I teach across the undergraduate and the talk graduate programs in the school. And this is a particular learning activity that I use in the undergraduate and in the talk graduate. So it's adaptable for different levels of learning. Just move on. Okay. So the learning outcomes, as I said, that are aligned to this activity it's an appraisal activity. And students are learning to identify appraisal tools that align with different research designs and/or guidelines. They compare appraisal tools and think about how different, what is the most appropriate tool to align with their research design. They critically appraise a paper either for trustworthiness, for the papers that are addressing meaning type questions, or for validity, replicability and reliability. And they do that using an appraisal tool which they apply to their paper. Ultimately, the purpose of this is to judge the value of the paper. So that's one of the learning outcomes. And then finally, the final learning outcome is to recommend what elements of the paper can be translated to practice. So this is, I suppose, it's a workshop that we run with students. So they're divided into groups of 4. Obviously, pre-COVID, this was all done face-to-face with students, where they would be divided into their groups. They're asked to either bring a paper. So if the talk graduates who are completing their dissertation, they're asked to bring a paper that they have retrieved to answer their research question for their evidence synthesis. For the undergraduates, the paper can be pre-supplied, so you can choose a paper that's appropriate for their level. Obviously, during COVID, I had to think about how I was going to run these workshops online. And one of the unintended benefits of this project has been my exposure to murals. So I developed a mural that could be used on Zoom online classes. Essentially, the students are put into breakout rooms. So I'll go through, obviously, you can do this obviously face-to-face or online, but in the online on a mural, they're put into breakout rooms, 4 students in each room. And the breakout rooms are determined on what type of paper they're appraising. So they're asked, for the talk graduates, they're asked to bring a paper that's answering an efficacy question, an association question, or a meaning type question, and they choose their breakout room accordingly. They are asked then to also select what critical appraisal tool they'd like to apply to that paper. So I'm going to just, hopefully this will work and bring me into the Zoom. Okay, yeah, or into the mural. So I'm just going to show you how the mural works as a way of demonstrating the workshop. So they come in and they're all sharing this one mural platform, but they zoom into, how do I zoom with the mouse? I'll do this way. Okay, so they zoom into the area of the board that whatever their room number is. So room 1 are addressing an efficacy question. They could be pre-supplied, as I said, with a paper. The paper in this case is embedded at the top, the PDFs. They also, if it suits the learning purposes, they could also bring their own paper. Sorry, I'm not used to doing this with a mouse pad. Okay, so for the first 10-20 minutes of the Zoom, they work to support each other to apply the appraisal tool to the paper. And so they go through each question. In this case, it was the CASP randomized control appraisal tool that they used. And they would, sorry, I'm just going to try and zoom in a bit closer. They would, there we are. So they would move around the boxes. So there's a box for each CASP item. They would choose a color of Post-it notes that they're going to work with. And they would write their own responses to the CASP question item on the Post-it note and drag that Post-it note into the box for that question. They could do that either, you could do that either individually to if you have a shorter time for the workshop, get that to do that before they join the workshop, or they can do it together collaboratively in their group during the workshop. The next job after they've completed that and they've shared each other's responses, they need to drag their post-it notes down to the appropriate box. So this is allowing them to try and see how they can translate the appraisal tool to a synthesis or an appraisal of the evidence. So they can identify question 7 of the CASP appraisal tool. The RCT asks about what the results are. So you might drag the responses down into the key findings section here. Or there might be the question around blinding for the randomized controlled trial could be the responses to that item could be dragged down into internal validity. So it allows them, and they can also duplicate them where a response might straddle over internal validity and external validity if it's looking at sample composition, for example. So it's allowing them to practice together and support each other in not only applying the appraisal tool, but also interpreting the appraisal tool in terms of key concepts for critical appraisal. So how do I go back to?
I was jumping up because I thought I'd be easier to do it more quickly, is to just click back onto that.
Brilliant, thanks a million. So I'm just going to wrap up. As I said, that, oh God, I've gone back in. Shirley, how did I do that?
It's just a clip.
Here we are, yeah, I see.
The keynote.
So, no, there's something wrong there.
No, don't worry. It's a keynote there.
Brilliant. So you have to go mouse away from that. Yeah, thanks a million. Just to conclude, so that is an example of a learning resource that is available on Padlet. There's a summary of it as well as a link to the mural to duplicate or replicate the mural if you're doing it online. As I said, it's in a face-to-face, it's the same idea. You just use flip charts and sticky notes with the paper, with the students. It can be modified for a longer or a shorter session, depending on the length of time you have. A big emphasis on it is the peer-to-peer feedback because they're supporting each other to develop the tool. There's also built into a facilitator feedback as well at the end in terms of asking the students to then present their work and to make a case and judge the value of their paper. So I'll finish up there. Will I move on to the next? Okay, I'll leave it.
Yeah. Right. Good afternoon, everybody. As you heard, my name is Dermot Stokes, and I feel like a bit of an outlier in this group, since I'm neither a clinician or a academic. I am a librarian, and it's been a great opportunity for me to be involved in this project. So I am the college liaison librarian for the College of Health and Agricultural Sciences, and I support a lot of the schools that have been speaking here today. And when I talk about support, I support with teaching and research and other activities as well. And I have to say, if I sound uncertain, it's because there's been so much information. I've pretty much had to rewrite what I was going to say as we've gone through this morning. It's been a great learning experience for me, and one of the things that there've been certain implications that I think have been taken on board is that traditionally we've gone with a one-shot delivery format in how we support the students in teaching, and a lot of what we've been talking about is when things happen. So is the one shot the best thing? Is it more targeted? Is it a variety of approaches that we would deliver? So maybe I pop in for 10 minutes to talk about a specific thing. Is it a video? Is it a flipped classroom? So there's just so many options that are available there for you. And when we were going to the 5As, I kept seeing lovely bits of information. I said, yeah, we can. This is really what the library does and what we've got the expertise in. And I can see stuff that's popped up a number of times. Pico has been sticking its head up multiple times as we've gone through today. And there are various areas here where the library has strengths and there are opportunities for the libraries to work with the schools as we go forward. And it's to have those conversations and have the dialogue to make sure that what we have our own opinions about what we should be delivering. You have your opinions about what we should be delivering. It's having that debate to make sure that we're doing the best for the students. And these are some of the things that I think that where we have to have the dialogues that's happening. We need to make sure that our collections are there properly to support evidence-based practice. So not only for the students to make sure we have the books and resources to support the students, but also as evidence-based practice comes wider around, that we do have the collections in there for the educators as well. So we do have processes in UCD to get that, and I'm sure in your own institutions you have those as well. So just make sure you get that, and hopefully it'll be sort of a slightly more modern collection policy than we have on the screen there. We have over the years developed loads of resources. We have a specific section on the library website where we have information focused on a student, researchers, etc. So it's aimed at different levels, so they're all available for them. And one of the things that was very conscious for me as this morning went through it is this is a perfect time for having this dialogue, because we're aware that a lot of what we've developed, it's at its end of life. So we're going to be developing stuff. So it's great to have these conversations so that whatever we produce. So for example, in I have a student, we have videos and tutorials. Things have changed so much, interfaces, approaches, we need to update them. We've got subject guides where we highlight all the resources that are available for the students, how we got the right stuff there. So another avenue to direct students to. We've done, we do a lot with systematic reviews, maybe a systematic review guide there. And one of the unintended consequences for us of COVID is that we have, over the last number of years, done a seminar or a workshop on systematic reviews. We've recorded it. And we know that a lot of, well, a lot sounds is more dramatic than it actually is. We know that a number of lecturers have used that and then have done it like a flip classroom approach. We come in and answer questions. So all these opportunities are there for us to engage with them. We've done EndNote. We've had to redo the EndNote in Mac, Windows, EndNote Online, EndNote 20. It took me 2 years to get my hands on a Mac computer, another 2 months to figure out how to use a Mac computer, but it's all there. And it's improved, it's allowed us to redefine what level we engage with the students. So we give them the basic tools, and if we never hear from them again, then they know how to use it. And if they come, it's a higher level approach. So all that is really, really good. It's not just me as well. That's the other point I have to make. There are other people, like in the College of Health and Agricultural Sciences, there's 2 of me. So we just need to get everybody on board and build that up. And also just to point out is that it's not just me delivering training in the library. There are experienced people dealing with a wide range of it, and we run a lot of training opportunities. So it's exploring those, and then maybe necessarily they might be the proper person to invite in to deliver a session on a topic that would be a higher value, higher quality, because it's not my area of expertise. So, and the librarians always love that. And the great thing about if it's a hybrid way, you record it, and then it is then available again and again and again and again. So these are just some of the ways I think the library can work with you. And I think I've run out of slides and time. And as I said, I do feel like a very welcome, but a bit of an outlier. And I really would, if you have any questions or comments about how the library has supported you, or how we can, or how you think we can do a better job in supporting students and yourselves, we'd be delighted to hear about it. So I don't know who's up next.
Thank you very much. It's a pleasure, and I'm very thankful to be asked here to talk at this seminar today. My name is Joseph O'Sullivan, and so I have here a student and practitioner's perspective, and hopefully putting those 2 together, I can call myself an evidence-based practitioner. But just to give a little bit of background quickly, I graduated from UCD in 2015 in veterinary medicine, and for the following 5 years I worked in general practice. And amidst those 5 years, I was very lucky to partake in and complete the graduate certificate in small animal medicine here in UCD, developed and run by Dr. Emma O'Neill. And luckier again that there was a huge emphasis in this certificate on evidence-based veterinary medicine and evidence-based practice. And so after that, I actually was just the past couple of days, I was looking back on some of the personal reflections that were written during that certificate. And I found down the end, and can't remember writing it, that, you know, this may spur me on to further learning. And since then, I have gone on to do a specialist internship in surgery in private practice, and now found myself in an academic rotating internship in the UCD Veterinary Hospital. So it definitely did that. And I'm hopefully carrying the evidence-based approach with me throughout. And so just to touch on the graduate certificate, so there was a huge emphasis on evidence-based veterinary medicine. And that was the first module was entirely based around that, and then incorporating that into looking at system-based advances in veterinary medicine. And what I would say is, whether I didn't appreciate it at the time, but there was very little evidence-based practice experience that I gleaned from my undergraduate degree in veterinary medicine. And I think it's, you know, really positive to see this framework. And if that was there 10 years ago when I was starting in stage 1, I think would be really beneficial. But in this graduate certificate, there was a number of general practitioners from varying knowledge and skill set coming together, from new graduates to established practice owners. And in this first module, we really did explore and apply the 5 A's of evidence-based practice. And alongside that, what I really liked about this was there was a lot of innovative teaching methods throughout this certificate. There was these little snappies that were lovely, small nuggets applied practically to inform, looking at case-based, short case-based and problem-based examples. But what I'm going to focus on really, and what I felt was, you know, important in the teaching of evidence-based practice, was the peer-to-peer learning, and that was a huge thing throughout the certificate, and discussion, debate amongst the students, and also the use of non-veterinary topics. And there was other things like our concept maps and critically appraised topics that tied the whole lot together. But our first assignment, when we just started, we were presented with this clinical scenario, and this is the first of our 5 A's. And it was really nice. It was a breath of fresh air, because we're coming from busy veterinary practice, and taking a scenario from human medicine. So you meet up with your father at the weekend. He has been a long-term smoker, but recently become aware of worsening health signs and wants to quit smoking. And he asks you, should he consider e-cigarettes? And what was really nice about this, there was practitioners coming from different skill sets, knowledge base, and this just leveled the playing field, and it made it a really nice environment to just focus on the principles and focus on the method. And my good friend here, the PICO, we formulated our answerable clinical question, and does the use of electronic cigarettes by a long-term smoker lead to improved success in quitting, and then whether we had our comparative or not. And so then, taking this along, we're using our acquire and using our Boolean search strategy, and applying that. And amidst this happened over a number of weeks, and we had our peer-to-peer discussion, and it highlighted some really nice debate and discussion. And there were some smokers, some non-smokers, and it showed some nice discussion. And then we're looking at the appraise and showing up, you know, some of those studies that we found, systematic reviews, clinical trials, and then learning to appraise those, again, away from the veterinary side of things, which was really, really nice. And then ultimately we put this all together, and we formed our opinion and our recommendation, and we found that the evidence was varied and contradictory, And from what we found, there are still harmful compounds, and I'd advise my father to steer clear of these electronic nicotine devices and pursue an alternative method. And then, of course, we'd have to start the process again. And so I think that really shows nicely the importance of having a an interdisciplinary example, but also the peer-to-peer discussion throughout that was really, really helpful. And then just touching on the co-design workshop quickly and bring that through. Personally, I found it a really exciting opportunity, and it was really nice. I was, heading to the, it was part of the top of Bloom's taxonomy, the creation. It was nice to be some small part of that. And then working through the workshops, I think just the big thing for me was, again, the multidisciplinary approach. And what I found, having completed the certificate, I had a good grasp of the 4 A's. I didn't have a good grasp of the 5th A. And, in general practice, I think especially as vets, we don't very much, carry out much audits and things like that. And then amongst the discussion in this co-design workshop, speaking to the different disciplines, I really got a good grasp of it and understood it. And that was, again, an example of the peer-to-peer learning. And, going on from that, understanding the audits and value-based healthcare in veterinary, we're always looking at the single patient. And I know that comes from the definition of our evidence-based practice, but, we don't tend to look at the, value or cost benefits and things like that. But I put this here quickly, just as maybe a quick highlight of what we kind of say the difference between evidence in veterinary medicine and medicine. And here I just did a quick PubMed search, and the top one was just surgical safety checklist. And I had 1,600 hits. And then by adding a veterinary term to that, I had 27 hits in the last 11 years. So in a sense, that just highlights the amount of evidence that we have available to us. But this was something that I worked on in the last hospital that I worked at, and came from the co-design workshop, understanding the audits, which I didn't understand before. And but it's just a little example to highlight that. So just from a personal point of view, that's some of these resources and some of these practices that were used within the graduate certificate and the co-design can be really, really helpful in teaching evidence-based practice. So that's it from me. I think I'm still on a steep learning curve, but getting there.
Thanks very much,
Thank you
Joseph. That's fantastic. So I guess I'm just coming up to wrapping up our presentation on the EVIBEC, and I thought that it might be useful for us to think about some of the outputs we had from the process, because I think there's a little bit of learning in that. And I think every day is a learning day has always been my motto. And I hope that that's something shared by everybody here. So we found that we got introduced to Mural by Charlene, and all of us are addicts now. I think Mural's been a fantastic learning platform and sharing platform, and it's very, very good for collaboration linked to Zoom. I think there's always some learning out of a big storm like COVID, and it actually did us a big favor, I think, putting our workshops online, because I'm not sure we would have had 33 attendees if we'd been face to face, and we'd have struggled with the timing. So I think that's something that's worth taking forwards, because the Zoom platform works very well for that. The co-design approach, we've heard from Joseph, I think he speaks this for a lot of the students, that they found it a powerful learning experience, but so did we, hugely so. And that's something that we forget to draw on sometimes. The interdisciplinary linkages and sharing of resources and development of a community of practice is really what where we started from. And I think we share that with everyone in the room and virtual room, and is something that we'd love to see growing out of this going forwards. So I reiterate what I said earlier, that we think evidence-based practice is a very powerful conduit for interdisciplinary education, a good sort of starting point. and because it shares core common content and is a powerful way of building shared dialogue, and is probably the only way we're really going to get evidence-based practice truly to work. Because as actually I thought was very interesting that the students highlighted this, getting the patient voice within this process is really important and links back to what Eve said. But this is how we're going to do that, is if we actually embed this across. So I think I liked this because I thought that it really spoke to the fact that we have strength in our diversity if we embrace our diversity, and we should be learning by sharing and not reinventing the wheel and working in silos. So we've taken slightly longer to get to the discussion than I expected, but that's great because I think there's been an awful lot has come up. But I'm hoping now that we can have a discussion, and this is going to be the springboard of where we go forward.